Morning. Once again, you're welcome for our lectures, and today we shall be looking at urethral strictures. Per day, I just need to confirm that you guys are getting me clearly, and then I proceed.
Yes, doctor, we are around, and you can proceed.
Okay,
Hearing
that's very good. So today we shall be looking at urethral strictures, and these are not rare. They are conditions that you see lot in your practice, and I have made you guys are able to grasp urethral strictures. Urethral stricture can be defined as a narrowing, a diminished urine flow, and we should include spongiofibrosis. So urethral stricture is a common condition both in developed and developing countries, but the pattern of the causes in the two different scenarios are different, and strictures can occur in both males and females, although it is more common, of course, in the males. The male urethra is much longer than the female. The female is about 4 centimeters compared to the male, and it is more exposed to various forms of trauma, being longer than the female. The male urethra is more predisposed to trauma as well as infection, both of which are causes of urethral strictures. So in the etiology, of course, we have the infective causes, the most common being gonococcal urethritis, and that one usually comes with pus, frank pus by urethra. Chlamydia is also implicated, and these infections, especially gonococcal infection, was causing more of the strictures in the olden days. But with effective antibiotics now and better medical seeking behaviors, the trauma has actually in the infections very fast. So the infections, most of the literature says trauma has taken. And this trauma includes the falls, the straddle injuries. An example of a straddle injury is if someone falls in a deep ditch with one leg in and one leg stays out. So the trauma is directly to the perineum. And that's a typical example of the straddle injuries. Of course, patients with pelvic fractures will also tend to have urethral strictures. And these ones are usually very high because the disruption usually is at the membranous or the bulbomembranous junction. That is connected to the anatomy. When the pelvic fractures happen, they actually, when they displace superiorly, they move with the prostate, because the prostate is connected to the pelvic bone by the puboprostatic ligament. And therefore, when the fracture displaces superiorly, then it pulls onto the prostate through that ligament. And therefore, the prostate detaches from the membranous urethra. And so they are usually deep. And they actually also involve the sphincter, the external sphincter of the urethra. There are some also that are iatrogenic, and these ones include the catheterizations we do. And that's why I usually emphasize that when we do catheterization, we should do the standard procedure, not just getting KY jelly and you push without any anesthesia. You need to do the procedure standard. So catheterization, urethral catheterization, during cystoscopies, basically instrumentation of the urethra can cause some bit of trauma. Of course, TURP, endoscopic prostatectomy, can also cause this trauma. The other causes are malignancies, and they can also cause narrowing in the urethra. So in the pathology, so the instance of the pathology of urethral stricture is actually fibrosis of the corpus spongiosum, and this is the penile body through which the urethra runs. We know that the urethra runs through the corpus spongiosum. And in strictures arising from infection, an intense inflammatory process is set up in the urethra and the surrounding spongy tissues. And the healing is by fibrosis. And of course, the fibrotic tissue has an inherent tendency to contract, and therefore this contraction leads to the reduction in the urethral lumen. And of course, eventually, there may be complete obliteration of the urethra. That means the patient doesn't have any urine at all leaking through the stricture. And these are patients who will finally get complications if they don't get the medical attention they need. So in the case of trauma of the urethra, as we talked about, we said these ones are high, and usually the prostate detaches. So you have a gap which is filled by a hematoma, and this hematoma is invaded by inflammatory cells, and in the ensuing weeks or months, the hematoma is organized into a fibrous tissue, and the rest of the process, of course, is the same as in the infective strictures. So the lesion that results from pelvic fracture and injury to the urethra is often described as pelvic fracture urethral destruction defects. And this puts emphasis that it is not strictly a urethral stricture, but rather the blockage of the urethral lumen that results from the urethra being transected, and a mass of fibrous tissue forming in the hematoma that forms after the injury. So a patient may have a single stricture or multiple strictures, and we shall see the images later, the urethrograms. And when you read these urethrograms, you should be able to tell us whether the stricture is single or they are multiple. The stricture is also described as being anterior or posterior. And the anterior urethra is considered to include the penile and the bulbous. So if you find a stricture in those two, you describe the stricture as being in the anterior urethra. And when you say anterior urethra, you go ahead and specify whether the stricture is, the stricture can also be posterior if it is in the membranous or prostatic urethra. Now, because of the numerous periurethral glands in the bulbous urethra, the strictures are commonest there, especially the infective causes. Gonococcal infection will mostly of the numerous periurethral glands there. The prostatic urethra is membranous urethra is the most commonly affected site. The female urethra is not commonly involved. The cause frequently being either catheterization or birth. You'll also meet so we're saying the female urethra is not commonly involved, but occasionally one does see a female with a stricture. The cause frequently being catheterization or some other form of instrumentation or childbirth. The other cause that I saw in Tanzania quite a lot in the Maasai was in those cultures where there is female genital mutilation, and usually you will find stenosis of the urethral meatus, and so some of those patients also you should look out for them. I forget the tribes in Uganda that practice that, but that also causes strictures in the females. So when these people get urethral strictures, we say there is narrowing. And so in the clinical presentation, then you should expect to have the lower urinary tract symptoms that we discussed in the beginning. I think that was our first lecture, the LUTs. And we categorized them in 3 categories, into the irritative, the obstructive, and also the others. And so when the guys get these strictures, when narrowing happens, then in the
Doctor, we can't hear.
clinical presentations, you have the network is disturbing, but I think we shall manage. So is this where we got off? We're on the clinical presentation. No, it was before.
That's where we got off from.
Okay, so let's proceed there. So we're saying the high frequency can happen because of the incomplete bladder emptying. The patient empties the bladder halfway, and therefore it gets full very fast, and that leads to the increased frequency. But we have also said that the frequency may also arise because of infection. When the bladder is irritable, then someone will tend to urinate many more times. Dribbling means even after urinating, there's still some urine that drops. And of course, these patients will usually end up having urine retention. The last time we talked about the LUTs, we agreed that urine retention can be acute or chronic. And we said acute urine retention is painful, but less dangerous compared to the chronic urine retention, which is non-painful. So they can have urine retention, and this is one of the common presentations in our setting. So patients present late, they wait until they get into retention. The patients may also have hematuria from infection in the bladder and the urethra. And also, you can have symptoms related to the complications. We know that hernias are caused by straining, so when they strain to pass urine, they can usually have hernias, rectal prolapse, and urine extravasation. And urine extravasation is like the last complication, the bad complications of urethral stricture when someone has not got treatment. I think later we shall meet something called the watering can perineum. That when the urine has nowhere to pass, then it starts causing infection with small abscesses that finally break and make several urethral-cutaneous fistulae, and then you have the watering can perineum. So in the physical signs, the specific signs of urethral strictures are few, and they may include a palpable urethral induration. If you palpate along the urethra, you may actually feel the scar tissue that will feel a bit hard, and that's what we call the urethral induration. These patients may also have hypertension, because we know that if these strictures are not treated, then you have incomplete bladder emptying. Finally, you may have hydroureters and hydronephrosis. And of course, when you reach those stages, then the kidneys may be affected. And renal insufficiency, we know that will lead to hypertension. We can also have inguinal swelling. So when you examine these stricture patients, you should make sure that you rule out inguinal hernias and prolapsed rectum. You can also have the perineal fistulae, which you already termed as the watering can perineum, and sometimes the kidneys may also be palpable due to hydronephrosis. Now, in the diagnosis, the most important diagnosis in relation to a urethral stricture is the urethrogram. And the urethrogram, we can have the retrograde urethrogram and the antegrade urethrogram. So the retrograde, these are contrast studies. So you want to push in contrast and take pictures to show you where the stricture is. So when we talk of retrograde, the contrast is pushed through the external urethral meatus. So a catheter is inserted and then ballooned in the fossa navicularis, and then contrast is pushed retrograde, and pictures are taken. Then the antegrade, for you to do it, you need to have an SPC. So through the SPC, you put contrast in the bladder, and then you ask the patient to urinate. As they start urination, as they're urinating, you take pictures. And so that is the antegrade, because you introduce the contrast in the bladder and the patient is asked to push to urinate. In other words, the contrast is taking the antegrade route, because that's normally how the urine flows. The retrograde, just to emphasize, You put the catheter through the external urethral meatus, just slightly in. You balloon it in the fossa navicularis with just 2 mils, and then you push the contrast through the catheter and you take pictures. So this is the standard imaging investigation for the urethral strictures. And they are both important because they give you important information. Each is responsible for giving you some information about the stricture, and we shall see later how we interpret those images. There are instances when the images are not very clear, and you may want to do urethroscopy. This is endoscopic, so you can do urethroscopy and appreciate the stricture. The other supportive investigations, of course, are urinalysis, because we say these patients are predisposed to infection. An ultrasonography will be able to show you the bladder. If there is retention, it will show you residual urine volume after urination. It may show you a stone if there are stones forming there. It may also show you hydronephrosis and hydroureters. And so an ultrasound scan is very important. Kidney function tests for obvious reasons, and a full blood count. We know that in kidney failure, you may have anemia, because we know that the kidneys are also responsible for red blood cell manufacture. So the full blood count is also important for us to look out for anemia in case there is renal insufficiency. So don't forget that the most important imaging investigation is the urethrogram. And there are 2 types of urethrogram. There's the retrograde and the antegrade. The retrograde is usually what you do initially. For you to do the antegrade, you must have SPC. So being the most important imaging investigation, we shall dwell so much on the urethrogram so that you get an idea of how you read them and how you interpret them. So for all urethrograms, standard urethrograms, there must be a scout film. A scout film, we mean that you should have an X-ray of the pelvis before contrast is given. And when you look at this image, these are images, some of them we see the patients in the clinics, so we take pictures. And you can appreciate that in this picture, there is no scout film. Okay, all the films have contrast in them. So this is, if you are commenting, if you are reading this image, your comment should be that it is not complete because there is no scout film. And the scout film is supposed to just be a plain X-rays. The scout film is just meant to show you if there are fractures, pelvic fractures, because we said pelvic fractures are actually one of those causes of urethral strictures. So you want to see if there are fractures, especially fractures in the pubic and the ischiopubic rami. A fracture in the ileum does not have any connection with the bladder, so with the urethra, so it will not cause strictures. So you are more interested in fractures in this area. And so we are saying fractures involving the pubic bone and the superior and inferior ischiopubic rami. If there are fractures involved here, then they are capable of causing the fractures. So in the scout film, you are looking out for pelvic fractures, and you are also looking out for stones. If this was the plane, because now this is not plain because the bladder is there, it's full of contrast. But if it was plain, then if there's a stone, you should be able to see a stone, and you should be able to see your fractures. So when you start reading the urethrograms, you start with the scout film. And those are the 2 things you look out for on the scout film. You want to tell us whether they are fractures or whether they are stones, and that's all. Then after the scout film, then you move to the retrograde urethrogram. And the retrograde urethrogram in this picture is this one and this one. These two are retrograde. Why? Because you see there is a catheter there and this is dilated, okay? The urethra there is dilated and the stricture is that narrowing there, okay? This narrowing at this point. And in the normal urethra, in the normal urethrogram, if you do a urethrogram and it is normal, all this will be open. There will always be that narrowing at the end, okay? So this should not confuse you for a stricture. This is just at the sphincter. In other words, when you see that tapering, it should be nicely smooth, and that indicates that that is the membranous urethra. And the best way to differentiate, because sometimes you have strictures at this point, and the way you differentiate is that if it is the tapering of the sphincter, then the tapering is smooth. Like in this picture, you can see it is very nicely smooth there. But when it is a stricture, it will end abruptly, okay? Even in this image, you can see the urethra, there's a narrowing here, so there's a stricture. But after the stricture, that narrowing is smooth and it is normal. This one is the narrowing of the sphincter. So this narrowing should not confuse you. And even the narrowing, just after that point, you rarely see it open there. This opens in the antegrade. So in the retrograde, don't expect an open prostatic urethra and the membranous. They are closed and the tapering is smooth, and that's how you differentiate the strictures. So these are the retrograde films, and I've showed you that there's a catheter at the tip, the contrast was pushed, what you see as white is the contrast, and there's a narrowing there, and this narrowing we have said is normal. It is at the sphincter. Then the antegrade, these are retrograde, so the lower ones are the antegrade. And you can see that first, the bladder was filled with contrast, okay? And then the patient was asked to urinate, and you can see that the bladder is there, the bladder neck is open at this point, and you can see that the urethra, the prostatic urethra is open, and part of the bulbus is open up to this point. When you reach this point, there's narrowing. You don't see any contrast. You don't see a continuation of this. So the stricture is at this point. And therefore, for you to find the length of the stricture, you combine the picture of the retrograde and the antegrade. You can see exactly where the antegrade, the contrast stops, is almost where you see the narrowing in the retrograde. And so you use that combination for you to actually estimate the size of the length of the stricture. So in the retrograde, you'll be able to know whether the stricture is incomplete or complete. You will also be able to know the distal end of the stricture. This one is very easy because it is incomplete, but just imagine that you had a complete stricture at this point. That means you will not see this contrast this side. You only see contrast up to that point. Now, if you see contrast ending abruptly here, it means on retrograde, you cannot know how far the stricture then goes, because the contrast will end abruptly. And that's why we are saying, for you to know the length of the stricture, you should have the antegrade, because then the antegrade will show you the bladder neck, and the open urethra that is proximal to the stricture. So if this was a complete stricture, you see that way until it blindly completely disappears. Then you can know in the antegrade it disappeared at this point, in the retrograde it disappeared at this point, and then you estimate how much distance is between the distal, okay, the distal end on the retrograde and the proximal end in the antegrade, and then you can estimate the length. This diagram is not showing the stricture clearly, but don't worry about the stricture. It is meant to show you more about the diverticuli. Okay, so in the complications of the strictures, you can also have diverticuli in the bladder, and you can see there are several in this picture. Okay, there are several diverticuli, outpouching of the bladder mucosa, and you can see those diverticuli, and this picture shows them very clearly. This is also another picture of another patient. Okay, and we can see that for this one, at least he gave us the plain film, or what we call the scout film, and you can tell that there are no pelvic fractures seen. Okay, and there is no there's no stone. There is no stone seen in this bladder. And then after that, you look at the retrograde. Okay, and the catheter is put, contrast is pushed. You can see all this is nicely white. It is not narrow, but when you reach here, there's a narrowing there. And then this is normal. We already talked about that smooth tapering. You can see it here. And we say that smooth tapering is the sphincter and should not be confused for a stricture. But you can see that there is one incomplete stricture in the penile urethra. Now, the only way you know where you are is because after the penile urethra, the bulbus is actually dilated, okay, normally. So you can see the urethra there is normal. When we reach about here, then there is a bit of dilatation that has happened. And that dilatation is where the bulbus is. So you can tell whether the stricture is in the penile or the bulbus. And of course, the smooth tapering is there also. That is also the retrograde, just showing you the stricture there. And if you look carefully, you can also see that there is a diverticulum at this point on the bladder. And also the bladder outline is not smooth at this point. And the bladder mucosa should be very nicely smooth. But you can see a diverticulum there. And it's a bit rough down here. So that is not normal. So this is another patient with a urethral stricture also. And you can see that they gave us a scout film, and you can see that there are no fractures in the pubic bone, in the superior and the inferior ischopubic rami. There is nothing like a fracture in this one, and there is no stone. If there was a stone, you would see it here. Okay, they usually look like an egg. Depending on how big they are, they'll be in this position. So in this one, there are no fractures and there are no stones. We said after you've seen the scout, then you go to the retrograde. The retrograde is here. How do you know it is retrograde? Because the bladder is not full. Okay. In antegrade, we said you must first fill the bladder and then ask the patient to void. But this bladder is not full to capacity. So this is not an antegrade. And we also said that you see a catheter at the tip of the penis, and then they push contrast, and you see dilatation of the dilatation of the urethra. And you can see there's extravasation of some contrast. But more importantly, you can see the urethra. There's a bit of narrowing here, just a bit. And then you move, and you find that there's a stricture, and you can see this narrowing is not a smooth tapering. So this is in the bulbus, and there's a long stricture. Okay, there's a long stricture, and now this is what we are talking about. So from this picture, you can see the distal end of the stricture. But what happens up here, you are not sure. And that's why it's important at this point now to do the antegrade, or what we call the voiding cystourethrogram. And the voiding shows you the bladder. It shows you the diverticulum. There's a diverticulum there. Shows you an open bladder neck, which is at this point, and shows you the open proximal part of the urethra. And it opens up to this point. Okay. Now, if you compare with the retrograde, you can see that the proximal bit from the stricture is not seen. And therefore, the antegrade shows you the proximal end of the stricture and the proximal urethra that is open. So that is the bladder. This is the diverticulum. This is the bladder neck, which is open. And this is the prostatic urethra and part of the bulbous urethra also. And it shows you at this point, that's where the narrowing is. Okay. So the proximal end of the stricture is at this point. The distal end of the stricture is at this point. So that's what I was saying, that now you estimate, you see from the retrograde, the end is there, and the antegrade, the stricture stops there. So you estimate the gap between there and where you think the stricture ends distal. So I hope you have a good understanding of the urethrograms. We shall see. If you have any questions, we shall see them at the end. So when we've made our diagnosis of the stricture, then let me just connect my charger. So when you've made the diagnosis, then you want to treat the patient. Now, there are different options of management, of treatment, and we shall see the factors that influence your choice of treatment. And one of them is the type of stricture, whether it is infective or traumatic, if it is single or multiple, if it is a short or extensive stricture, or what we call the long strictures. So it can be short or long. And I will give you the details as we look at the specific modalities of treatment. And the stricture can also be complete or incomplete. Complete means there is narrowing completely blocked, and incomplete means there is narrowing, but there's still a small gap where urine can pass. The other factor to consider is the location of the stricture. So the location of the stricture, you can have the stricture in the penile, in the bulbous, in the membranous, and the prostatic. Of course, we said in the prostatic, they are very rare. Now, why this is important is because we know that, first of all, the penile urethra is fixed. It cannot be mobilized. It cannot be mobilized to make it free. And so in penile strictures, you may not be able to do what we call excision of the stricture and primary anastomosis, because the urethra cannot be mobilized. In the bulbous can be mobilized, and therefore you can do some, you can, for example, do the excision of the stricture and primary anastomosis. Similarly, the membranous, you can still do excision and primary anastomosis, for example, because the membranous is just next to the bulbous. So you can mobilize the bulbous towards the membranous, much as the membranous is fixed. The other things to consider when you are choosing the treatment modalities is the age of the patient, and if the patient has any other comorbidities. If there are comorbidities, then you want to use the minimally invasive modalities. Yeah, of course, the other one that is serious, the availability of equipment and the expertise. And these also determine on which methods you may want to use. Now, in the treatment options, we have dilatation, we have modalities, what we call DVU, direct vision urethrotomy. We also have open surgery. And this open surgery may be single stage or multi-staged. It may be with substitution or without substitution. It may, you may also want to just do a perineal urethrostommy. The perineal urethrostommy, we shall just go through slowly by slowly in each, so that you understand. So when there's narrowing, we have instruments called bouges, and you can use bouges to do dilatation. But we only use bouges if the narrowing is not much. If the narrowing is not much, then you can use the bouges. And the bouges are in different sizes. They are metallic instruments that you pass through the urethra up to the bladder. So you start with the smallest size, and then you go on increasing the sizes as you put KY jelly and slide the bouges through the urethra up to the bladder. So you keep increasing sizes. In other words, you keep dilating as you increase the sizes of the bouges. The other method is the endoscopic. The endoscopic, you have a screen and a camera, and you have your instruments. We shall see a short video shows that. And it's a guide wire, and then you follow the guide wire. It will be your guide as you cut. So as you cut through the stricture, the stricture actually keeps the stricture just keeps getting wider and wider, and then of course you pass a urethral catheter. We shall see a short video of the endoscopic, and we can use the cold knife. The video we shall see has a cold knife, but in better settings, some people are using laser. Now, for you to do DVU, the condition is the stricture must be incomplete. The stricture must be incomplete. You cannot do DVU for strictures that are complete. Why? Because, as you'll see in the video, you must pass a guide wire through the narrowing, through the stricture, so that as you cut, that guide wire actually helps you not to cut off where you would want to cut. So without the guidance of the guide wire, you cannot do DVU. You will injure the patient. You find yourself in the corpora cavernosa. And therefore, for endoscopic surgery, the rule is that the stricture must be incomplete. The other things that enhance healing from DVU is that the stricture should be short. And by short, we mean 1.5 centimeters or less. And the stricture also, if it is in the bulbous, the healing, and of course, if there is little sponge of food, it is more successful if the stricture you are dealing with, first of all, the stricture must be incomplete. Secondly, it is better for strictures in the bulbous urethra, 1.5 centimeters and less. And lastly, the spongiofibrosis should not be a lot. So that is when the surgery is likely to be curative. But that is to say that if the stricture is, for example, in the penile and is incomplete, you can still do DVU. Similarly, if the stricture is 4 centimeters, it is incomplete, you can still do DVU. Basically, DVU is an option as long as the stricture is incomplete. But the best cure rates are got when the stricture is short, 1.5 centimeters or less, is in the bulbous urethra and has little spongiofibrosis. So that is about the endoscopic treatment. Now, for open surgery, we are saying that you can have single stage or you can have multi-staged. Now, either of these has also with substitution or without. In other words, you can have a single stage with substitution or single stage without substitution. You can also have multi-staged urethroplasty with substitution or multi-staged urethroplasty without substitution. And therefore, the open surgery is basically called urethroplasty. But it can be, just know that it can be single stage or multi-staged. And both in these scenarios, you can have with substitution and without substitution. So buccomucosal grafts, BMG, buccomucosal grafts are currently the recommended. But when we do grafting, or when we do the substitution, we can substitute with buccomucosa. We can also even use skin graft. We can also use the tunica vaginalis. Basically, we can use different tissues, but buccal-mucosal grafts now are the best. And if you do open single stage without substitution, it is called EPA, excision of the stricture and primary anastomosis. That means you see the stricture, you operate through the perineum, identify the urethra, identify where the stricture is, cut off the stricture, and re-anastomose. You anastomose the urethra. So the EPA is good for short strictures, and these strictures should be in the bulbous urethra. And we said in the bulbous, why it is possible for you to do EPA is because the bulbous urethra can be mobilized. You can mobilize it, and therefore you can do your anastomosis without tension and without causing curvature in the penis. If you try to do excision and primary anastomosis in the penile, you may do it, but the patient will have curvature, will have a ventral curvature of the penis, and you don't want that to happen. Now, so this is good for strictures in the bulbous, and it is good for strictures that are 2 centimeters and less. Okay. If you have strictures that are longer than 2 centimeters, then you may want to do single stage with substitution, for example. If you have an incomplete stricture that is maybe 4 centimeters, then you may want to do single stage with substitution. Okay. And then if a stricture is longer than 4 centimeters, maybe is 8 centimeters, then there is no way you will harvest tissue to do it in single stage. So those are operations. Those are strictures you do in multiple stages. So multiple stages for longer strictures, especially strictures that are complete and longer than 4 centimeters. For you to do single stage with substitution, the stricture must also be incomplete. Of course, some of these are better when you've seen some of them, but I encourage you to go to YouTube and you can easily see what we mean by these. You'll understand them better. Now, for perineal urethrostomies, this one is a sort of a last resort treatment for strictures that you think cannot be treated, and what it involves, you leave the stricture alone and you just do a stoma using the urethra in the perineum, and so you call it perineal urethrostomy. So those are the options, and that's how you select the different options of management. So I would like to thank you for listening. And like I said, I want to share a video with you on the DVU so that this is an SHO. So I'm going to share the video. But are you able to hear the video? Can I continue?
Yes, we're hearing. Continue.
Oh, okay.
Or maybe if the sound could be increased to maximum.
Okay.
This picture, you can see how narrow it is. Now, the next thing is possible to do. The guideline has gone through. You are likely to hit it at the first stage, probably have a very dangerous assistant. So you push the guide wire until you feel resistance. That's the resistance. Okay. Now, so you load your blade. Okay. That's the blade. You load it just within where the guide wire has passed. See that it's getting wider. The cut should be at 12 o'clock. So I want to load the blade again. And see it's getting wider. Load again. Fast. And see it's getting wider. Cut. The blade again, like that. Cut. Okay, there. See, it is now wider. Now can proceed past this picture. up. Blood. That is the blood.
Okay, so that brings us to the end of our lecture today. Yeah, I saw someone, I think, asking to have the video. You'll have it on your WhatsApp. Yeah, I think I'll just take I'll take a few questions, maybe.
Yes, doctor. We have, yeah.
Then
Josephine,
I prepare to run for the clinic.
Okay. Josephine, please unmute and ask your question.
Thank you, Doctor, for the lecture. My question is, how do you minimize the strictures that will come from healing after the surgery, given the fact that surgery is in itself a form of trauma? That is for the options of surgery in treatment. Thank you.
Okay, thank you, Josephine, for your question. That's a very good question. We had a saying that the stricture either kills you or you die with it. Because we've seen through the pathophysiology that actually the scarring is the problem. And when you operate, you leave a scar there. So that means that the strictures actually recur a lot. And especially DVU, the success rates are not as good as for the excision and primary anastomosis. The excision and primary anastomosis is much better because you are removing the stricture, much as you're leaving a wound, but you anastomose mucosa to mucosa, and you have higher chances of actually getting healing with very good results. Unlike DVU, unlike in DVU where you don't excise the stricture, but you make an incision in the stricture like we saw in the video. So you are right, the recurrence rates are high, depending on which method you use. Excision and primary anastomosis has the best results, but as we agreed earlier, you cannot use it for all strictures. There are some strictures that may be better treated with DVU and the multi-staged procedures. Yes, thank you. I see Jonathan also.
Miro raised his hand up, so let Miro first ask, then we shall end with Jonathan. Miro.
Good morning. Yes, I've delivered lecture. So mine is a request. If we can have some questions, because the way the options depend on the location of the stricture, the length, which option to use in treatment. So if we could have a continued discussion on our WhatsApp, and you could share with us some of the questions about some of the patients, so that we can think through and try to see which method is appropriate for which type of patient. I think that would be really helpful if you could help us in that way. Thank you.
Miro, thank you. I think yours is not a question, but I realized on the group there are a few people who are active and the others just follow. And I think I tried to actually discuss how we select the different methods. We've said, for example, for endoscopic, the rule is that it should be incomplete. That means any stricture anywhere in the urethra, as long as it is incomplete, you can do DVU. But we said for better results, for DVU, it should be done for strictures that are 1.5 centimeters and less, And if they're in the bulbous, it is better. And if the spongiofibrosis is less. For excision and primary anastomosis, we said it is better for strictures in the bulbous because you only do them in sites where you can mobilize the urethra. So it's only for the bulbous, and the stricture should be 2 centimeters and less. Okay. And then we said for long strictures that you can choose to do multi-staged. Okay. And we also said multi-staged can be with substitution and without. Strictures that are longer than 2 centimeters, maybe 4 centimeters, that are incomplete, you can also do single stage with substitution. And we said we use buccal mucosa graft. So I have no problem. We shall continue the discussion, but just get those basics. I think I'll have one more question, and then we close it there. I see Morunji, Jonathan.
Okay. Thank you so much, Doctor. So this is Jonathan Morunji. I've had a chance to assist, I think, in one surgery with you about an excision and anastomosis. So my question to site surgeries which require the EPAs, excision and anastomosis, the urethroplasties. Do we still need to, can we use switches which are less than, okay, switches 3.0 or 2.0, you have to use 4.0 and 5.0, the likes of that. Then another thing is that in case you use, in case you're doing EPA, might you want to do, in case someone gets another stricture, is there a chance that you can redo it again, or when you use EPA is done, you don't have to? The chances of recurrence are actually low. Thank you.
Yes, thank you, Murunji, for the question. It is good if you have assisted or seen EPA, because then you comprehend these things much better. So the best sutures are fine sutures. They also increase your chances of succeeding. And when we are talking about succeeding, when you do these procedures, we are talking about total cure of the patient. Of course, that is relative, but the smaller the suture, the better. So the recommended is 4.0. Of course, if you're in settings and you are stuck in our settings where sutures are scarce, you can use 3.0. 2.0 is big, but in scarcity, people have used them. But the smaller the sutures, the better. So 4.0 is the recommended, and that, I think we should stick to that. Then you are asking about if recurrence happen, would you have chance to go back and do and repeat the excision and primary anastomosis? The answer is yes, but it is usually harder than the first attempt because you have fibrosis. Mobilizing your urethra will be more difficult. But if there is recurrence, you can still go back and sort the patient. Of course, if there is recurrence and it is incomplete and short, the best option would be DVU. You do endoscopic because it is less invasive. But if say it is if it is a total blockage, what we call complete, then you can still do excision and primary anastomosis even after recurrence has happened. I hope that answers your question.
Yes, it does. Thank you so much, Doctor.
Okay. Okay. With that, I think I would like to wish you a nice weekend, and to also remind you that COVID is still there. I think I had the investor talk about you guys coming back. If you can vaccinate, please vaccinate and take care of yourselves. Enjoy the weekend.